Hi, I'm Kimia Honarmand, and I'll be presenting an overview of principles in the care of patients with persistent critical illness. If you're thinking about your management of this patient population, and especially if you're considering designing protocols, programs, or just spaces that are geared towards the unique needs of patients with persistent critical illness, I'll propose some evidence and ideas for you to hopefully consider. First, some definitions. Chronic critical illness is defined as a state of clinical stability in a patient with continued need for prolonged ICU stay. The need for ongoing mechanical ventilation here in this definition may or may not be present. Persistent critical illness is a subtype of chronic critical illness in which the disease that led to the patient's ICU admission is no longer active, but there's ongoing organ dysfunction, often profound weakness, and psychological and cognitive deficits. This is commonly identified at around 10 days in the ICU. Patients with persistent critical illness make up 5 to 10% of all patients in the ICU, but they account for a third of ICU bed days, 15% of hospital bed days, 29 to 49% of hospital mortality, and nearly half of one-year mortality. So the condition is associated with high costs, high morbidity, and high mortality. These classifications that we've just discussed are different, are separate but closely related to defining patients based on their need for ongoing mechanical ventilation. And there are distinct approaches to classifying patients based on their duration of mechanical ventilation. One of these approaches is the WIND classification. Here, patients with ongoing ventilatory needs are classified into 3 groups. Group 1 are those who are successfully weaned on day 0 or 1 after first attempt at liberation. Group 2 are those that are successfully weaned between days 2 to 6 after first attempt. And group 3 are those still requiring invasive ventilation at 7 days or more after first attempt. Group 3 would be the ones that are more likely to experience chronic or persistent critical illness, of course. Another way to conceptualize weaning from mechanical ventilation is on a continuum that goes from acute ICU ventilation, which is intended to support the patient through the most acute phase of their illness, to prolonged ventilation, which is often defined as requiring ventilation for 21 or more consecutive days, to long-term ventilation, which is a condition of anticipated need for ongoing ventilatory support. And these patients would often be managed in a long-term ventilation facility for a prolonged period of time, if not for life, or in some cases, home ventilation. For the rest of this talk, we'll focus on patients in the middle group, those that are experiencing a need for prolonged ventilation, but are not necessarily deemed to be long-term ventilation patients. The care of patients in this group depends on a variety of factors, and we can categorize them into intrinsic patient factors, iatrogenic or ICU-related factors that often precipitate or exacerbate the risk of persistent critical illness, and systemic factors. That is the way that care processes are designed for the management of this patient population. And I really want to focus more on design and on ideas around designing systems that promote recovery from persistent critical illness. The basic principles of the care of ICU patients that apply to all ICU patients also apply to patients with persistent critical illness and patients with prolonged mechanical ventilation needs. So the ABCDEF bundle components, as an example, should still be applied to this patient population. But beyond these, there are unique aspects to the care of patients with persistent critical illness and prolonged mechanical ventilation that we need to consider. So we'll go through a number of these, including physical and functional rehabilitation, optimizing nutrition, weaning from invasive ventilation, and some general strategies there. optimizing sleep in a manner that's unique to this group, psychological and mental health, goal setting, and promoting a patient's ability to communicate. So physical and functional rehabilitation. We know that persistent and chronic critical illness are associated with higher incidences of critical illness polymyoneuropathy with symptoms that are described here. These symptoms and signs begin to surface during the subacute phase after the patients have passed through the very acute phase of their illness and are experiencing very severe weakness that often prohibits ability to wean from the ventilator as well. Many of these neuromuscular issues persist after ICU discharge, with muscle weakness and atrophy in approximately a third of patients, neuromuscular dysfunction in general in about half, and chronic pain in over a third of patients after ICU discharge. Strategies are needed that are tailored to this group. We know that early mobilization is important for all ICU patients, although not always applied and sometimes not feasible. Patients with persistent critical illness also require more consistent and more frequent rehabilitation. They'll benefit from a rehab team that's specifically focused on this patient population. A variety of prevention and mitigation strategies, for example, for entrapment neuropathies, are particularly important for this group who spends weeks to months in the ICU. Optimizing their functional status as the patient gradually gains their strength, for example, by engaging them in personal care activities like doing their own oral care or brushing their own hair. Those become important sources of motivation as well. Physical therapy should be done in tandem with weaning attempts, but this is not always the case. Sometimes this may mean postponing weaning targets until a patient has gained some muscle strength. And this can be fairly uncomfortable as ICU clinicians because we like to progress patients forward and get them off the ventilator. But sometimes, depending on the patient's physical function at the time, it may be necessary to, in fact, postpone or delay any weaning attempts until the patient has gained some muscle mass. A tailored training program has been shown to reduce time to weaning and decrease hospital stay and mortality. So if this is something that's not currently available in your unit, something to seriously consider. Optimizing nutrition is another important aspect. These patients are often malnourished. A comprehensive nutritional assessment would include evaluating their resting energy expenditure and tailoring their nutrition based on that. Avoiding overfeeding, which can inhibit weaning progress, and optimizing protein intake with a target of avoiding a negative nitrogen balance. And this can be measured by urine studies. Indirect calorimetry has recently been considered as the gold standard for assessing energy expenditure, and it uses pulmonary gas exchange, although there's mixed evidence about its effects on patient-important outcomes, and the device is not readily available in many ICUs. But if your unit looks after a lot of patients with prolonged ICU stays, this is something that you can consider. Similar to physical rehabilitation, sometimes in patients that are severely malnourished, it may mean that we need to delay ventilator weaning attempts until their nutritional status is optimized. There's a lot of interest in specific modes of ventilation that facilitate weaning in the so-called difficult to wean patients. The usual evidence-based approaches to weaning obviously apply to this patient population. For example, use of small tidal volumes during the acute phase of the illness, minimizing or eliminating sedation as early as possible, and so on. Beyond these measures that apply to all ICU patients, there's some additional principles to keep in mind for this for patients that are persistently critically ill. This is likely a familiar figure that conceptualizes the causes of weaning failure as a balance between respiratory load, so factors that place a burden onto the respiratory system, and respiratory capacity, which are factors that promote or could inhibit the patient's ability to overcome the respiratory load factors. So it becomes very important in the slow to wean patient to identify not just the signs of intolerance, but the factors that are contributing to it. That would mean identifying factors that decrease the patient's respiratory capacity, as identified here in this table, or factors that increase the respiratory load. And identifying each etiology for each patient is really going to facilitate targeted interventions to help with weaning. So what modes are centers using to facilitate weaning? In this study by Dr. Rose and colleagues, in which they surveyed 198 units that provide care to patients with prolonged mechanical ventilation needs, they reported a variety of approaches that centers use to facilitate weaning. The most common among these were pressure support weaning and twice daily trach mask trials. So not surprising findings based on our current practice. What's probably more prominent now is the use of Optiflow and PAV, which are increasingly used to facilitate weaning. And this study was in 2015, so not as prevalent at that time. So far, there's not a lot of evidence that a specific modality helps with weaning more than another, but there's a lot of talks at the CCCF that talk about specific modes and specific evidence. So I won't get into those here, but I'll try and summarize some general principles and approaches. We can visualize three different approaches to weaning. One is gradual weaning in a stepwise approach. So this would include, an example of this would be reducing inspiratory pressure on pressure support mode, every day that the patient is weaning, gradually over time. Another way to conceptualize weaning approaches is gradual weaning of a support mode with rest periods on full control ventilation. And a third would be a combination of full control and partial unloading, such as trach mask trials with periods of rest, full rest on the ventilator. So not a very common, necessarily a common strategy. So what are some of the principles that we've been discussing? It's obviously important to identify and address the underlying cause of weaning intolerance rather than merely identifying that the patient is difficult to wean. Addressing physical weakness and malnutrition first, and sometimes that may be before initiating weaning attempts. Studies have shown that weaning protocols that provide longitudinal consistency, those that are therapist driven, so driven by nurses or respiratory therapists, have been associated with higher weaning success in complex and difficult to wean patients. This makes intuitive sense because you can imagine that any really good weaning approach that is repeatedly changing every time one clinician hands off to the next has very little chance of success, no matter how good it is, because of the lack of consistency over time. And despite the fact that this seems intuitive, in the same survey that we just discussed of 198 units in Canada, weaning protocols were available in less than half of the units, and only 25% of those had weaning protocols that were tailored to the specific needs of patients with prolonged mechanical ventilation. So if your unit does not have a weaning protocol, and better yet, one that's tailored to this patient population, there's an important opportunity to improve outcomes by implementing protocols that provide longitudinal consistency, still allow for some individualization in a planned way, and ones that your team can agree to pursue over time. And finally, consider transitioning patients to non-invasive ventilation or CPAP as a bridge to liberation from invasive ventilation. Anecdotally, I can say that a high proportion of these patients, the patients that have a prolonged ICU stay and prolonged need for invasive ventilation, do end up requiring non-invasive ventilation or CPAP, at least for some degree of time nocturnally, as part of their weaning process. In general, this patient population, by the time they're classified as having persistent critical illness or requiring prolonged mechanical ventilation, by that time, they've already proven themselves to be not amenable to standard weaning approaches that we usually follow in the initial weaning attempts for most patients, like spontaneous breathing trials. So standard care, like minimizing sedation, addressing pain, optimizing sleep, and others are necessary for this patient population, but are not sufficient. A slow and steady approach is required often for these patients in a way that is very different from what we're used to in general ICU patients. Often weaning is limited by high secretion burden, which in the absence of active infection is a direct result of respiratory muscle weakness. Cough augmentation strategies are commonly used for patients with neuromuscular diseases or spinal cord injury, but not as often as they could be for patients with ICU-acquired weakness. Some cough augmentation strategies to consider, and this may require additional training for the respiratory therapy team. Lung volume recruitment or manual hyperinflation, percussion and vibration, and mechanical inexsufflation. Mechanical inexsufflation is not always available in all ICUs, but presents another opportunity to improve the care of these patients if you're designing a program. We know that sleep disruption is common among ICU patients. 2/3 of ICU patients report sleep disruption. 2/3 have atypical sleep patterns on EEG, and yet these estimates are likely to be much higher in patients with persistent critical illness. Sleep disruption, as we know, is associated with delirium, impaired respiratory muscle endurance, depressed immune function, and as a result, longer duration of weaning. All of these factors exacerbate the morbidities that are already present in this patient population. There's a plethora of risk factors for sleep disruption, but I'll identify a couple of those that we found in a systematic review that are more actionable or modifiable. These include factors related to the ICU environment, such as noise and ambient light, and certainly pharmacological factors, including minimizing sedation, but most of these patients that we're talking about are often already off of sedation. And then thinking about ventilatory strategies, especially at night, that promote sleep or at least don't disrupt sleep. So in this review, we found that pressure support ventilation was associated with greater sleep disruption on objective measures compared to both pressure control ventilation and compared to PAV. And of course, thinking about using a mode that reduces patient ventilator asynchrony during periods of rest, especially. There are a variety of strategies that can be used to facilitate sleep in all ICU patients. For this group, there may be an opportunity to cohort patients with similar needs so that you can tailor the environment accordingly, minimizing factors like light and noise in spaces where these patients are being cared for, minimizing daytime naps, scheduled quiet times, light exposure during the day, and then thinking about how to reduce sleep disruptions related to care. Do these patients who are often clinically stable really need vital signs every 1 hour or blood work at 5 a.m? So rethinking some of those things. And then consider the mode of ventilation during sleep. So the concept of respiratory muscle resting, avoiding under assistance. So as an example, do we really need to put patients on a weaning mode when they're in their rest period, when they're sleeping? And then on the other hand, avoiding over assistance, which may precipitate sleep apneas and sleep fragmentation. Psychological issues are very common in this patient population. Among patients with prolonged ventilation needs, nearly half have a diagnosable depressive disorder, and 17% of these don't have any psychiatric history. And as shown here in this study, these patients with depressive disorders in the ICU are more likely to fail to wean from the ventilator, have higher duration of ventilation, and even higher mortality. There's very limited empiric data on how best to address psychological distress and disorders in the ICU. Some potential approaches are indicated here. Having some degree of continuity of care, for example, by an experienced advanced practice nurse who can provide some longitudinal continuity of care. Providing psychological support by trained professionals, if available. Spiritual care as is appropriate. Normalizing setbacks for these patients, emphasizing that having complications or infections may be just part of their recovery process. Goal setting, and I'll provide an example of what we do in our unit. Recreational therapy, or engaging patients in activities that build motivation and reduce anxiety. Celebrating small wins or wins that we would consider, others would consider small. And engaging family members and certainly supporting family members who may themselves be experiencing mental health issues. Among patients with persistent critical illness, goals are an important source of motivation that can facilitate recovery. In the study by Dubin and colleagues, in which they asked patients to prioritize or to list their priorities, they found that the top 3 patient priorities were being able to eat and drink, being able to toilet themselves somewhat independently, and being able to walk. And so other priorities are listed here as well, but it's important for clinicians to recognize these priorities and devise strategies as a group to be able to help patients propel towards these goals as soon as possible. This is an example of patient how to capitalize on patient goals using a visual display. So this is an example of a display that we've used where the advanced practice nurse and the rehab team work with the patient to generate a list of milestones that the patient can strive towards, and then these are displayed in the patient's room in their view. And anecdotally, I think we've seen that this type of visual reminder is a real source of motivation and hope for patients who are otherwise feeling quite helpless in their circumstances. In the same study we discussed by Dubin and colleagues, evaluating patient priorities, they identified the ability to speak as number 7, above being pain-free and returning to usual activities. It's really important to facilitate the opportunity for patients to communicate their needs with the care team through the use of communication aids that are appropriate for the patient's abilities. For patients whose upper extremities are too weak for them to use a communication board, other strategies need to be considered. Speaking tracheostomy tubes may not be available everywhere, but are certainly not difficult to obtain and can be considered on a case-by-case basis. It also becomes more important to progress the patient to having cuff down trials and subsequently speaking valve trials as early as feasible, even before they're fully off the ventilator for 24 hours. And this may reduce anxiety, increase motivation, and be an event that's highly valued by the patient and their family. For a patient who hasn't heard their own voice in weeks, if not months, this can be truly a memorable moment for them and their family that can be celebrated as another win to motivate them to continue towards their recovery process. So in conclusion, it's important to identify patients who are at risk for persistent critical illness and may be beneficial to cohort patients with similar needs in order to tailor their environment and to synergize the care that the various members of the multidisciplinary team provide. Longitudinal consistency in care plans and weaning protocols is often an issue in acute ICU settings, but could be could be prioritized through multidisciplinary rounds to make decisions as a team. Having structured protocols tailored to this patient population has shown benefit for time to weaning and even mortality. Prioritizing other aspects of care, such as rehabilitation, nutrition, and sleep, are very important. And celebrating wins, providing patients support for patients' mental health, and engaging family members and caregivers. Ensuring that a patient has a mechanism to communicate their needs effectively with the care team, and progressing them towards being able to speak as soon as feasible. And in general, as we said, consider that this patient population has already proven themselves not to be amenable to the standard approaches to weaning from invasive ventilation and recovering from their critical illness. So for this patient population, a slow and steady approach is often needed to help with their recovery. Thank you for watching, and enjoy the rest of the conference.